All right, I'd like to welcome everyone to one in a series of the webinars that MedGlobal is hosting as part of our COVID-19 response. This webinar is part of our Flatten the Curve series, how COVID-19 is affecting clinics and partners in the countries where we work. We're providing accurate and up-to-date information to frontline healthcare workers, as well as the general public, about the latest research in this pandemic. We're working with our teams and our partners to provide support to the most vulnerable, some of the over 70 million refugees and forcibly displaced persons in the world. The effects of this crisis on the populations will be the most devastating, as many are confined to cramped environments like overcrowded camps or communities in urban areas where diseases can spread rapidly. This week, please join us as we will be hearing from two infectious disease specialists who will update us on the current state of the novel coronavirus global pandemic and speak to its effects on the populations where we are working. Our first panelist will be Dr. Uzma Syed, who is an infectious disease specialist in New York and has been practicing for 15 years. Dr. Syed's many exemplary credentials should be available to you on the screen. And I will now pass it over to you.
Thank you so much. Thank you so much for having me. I'm honored to be here today and to share some updates with everybody about COVID-19. I'm sure people have been following very closely as we are in an evolving pandemic. And just to give you a little bit of background on what's happening globally, things have changed quite significantly from when we first started hearing about coronavirus, the novel coronavirus outbreak, which started in Wuhan. And very quickly from December into January, we started hearing reports of it just out of China and from the Hubei province. And rather quickly after that, we saw that there was really worldwide spread of this novel virus, which has been classified as SARS-CoV-2, and the illness which it's contributing to is called COVID-19, as you're aware. So looking at this picture of the situation report from WHO, you can see that essentially in the last 7 days, you can see the updates on the number of cases that have been reported worldwide and all the countries that are essentially affected. And the shaded coloring just shows you, the prevalence, more prevalent areas than others. And if we're looking at specifically numbers, Johns Hopkins has a really great tracker that gives you a little bit more dynamic information on what's happening globally. Obviously, there's over 1 million cases worldwide. And there's a little breakdown over here, which shows over 400,000 cases reported in the US alone. And then after that, you can see that Spain has 146,000 cases, followed by Italy, 139. And following that is France, Germany, and China. So, we had surpassed essentially China's numbers quite a while ago. And, we're expecting for our numbers to continue to rise. And we're hoping that our mitigation strategies will help curtail that a little bit. And we've seen that starting to happen in Europe a little bit. If you look at the total number of deaths worldwide, it's listed as 85,000. But to look at something positive, the total number of people that have recovered is over 300,000. And if you just look at the active cases versus the closed cases that are happening globally, again, over 1 million people are being affected currently. Over 1 million people are said to be in mild condition, mild to moderate, I would say, and about 4% of the population is in somewhat of a serious or critical condition globally. And out of the closed cases, over 400,000 cases, we have about 300,000, a little over 300,000 that have recovered and have been discharged. And as I mentioned before, the 87,000 plus that have resulted in mortality. And these graphs over here just show you the algorithm and the logarithmic approach, the linear approach to the sharp increase in the number of cases that we have been seeing, as well as the number of deaths and mortality. Moving over to the United States, obviously this graph has changed quite drastically over the last, several weeks with the enhanced, community spread of this highly communicable illness. We've seen more and more cases being reported throughout the U.S. You can see the darkest areas, starting off with New York, which is the epicenter, and we had the maximum number of cases here within the US. And you can see that there's lots of other states that are having similar activity throughout the US, including you can see in Illinois, Michigan, Texas, California, Washington, Florida, and other states that are in lighter orange colors are showing some effect as well. Cumulative total number of cases from the CDC in the US. This is reported numbers from January till April 7th. And you can see, again, we have this linear increase in number of cases being reported. A lot of this, obviously, we were anticipating increase in number of cases as our testing availability became more prevalent. So the more we are assuming that the more we are testing, the more we are going to prove the amount of illness that is there, that is prevalent. But that's really important in the perspective of a pandemic to really have the actual number of cases reported and tested so that you can really come up with that denominator and that case fatality ratio that we're going to want to look at in the future to see how many people are actually affected by this and what was the ratio of that mortality. So we really need to have that denominator, which is the total number of people that are affected by the illness. Cases of COVID-19 reported in the US by source of exposure. So interestingly, travel-related cases was a little under 2,000. Close contact was reported as roughly about 8,000. And then we have all these cases that are significant, that are under investigation currently. So we'll have more details on this later as time goes on. Now, the CDC breaks down by states the number of cases that are reported, correlating to that graph that I showed before, the map of the United States. So you can see the areas that are, widespread illness. We can see in California, 15,000 cases, over 15,000 cases. In Florida, you have over 14,000 cases. Illinois, we're over 13,000. Louisiana, as you must be aware of in the news, significant number of cases and mortality going on there, over 16,000. Massachusetts has a good amount of reporting as well, 15,000. Moving on to Michigan with over 18,000 cases, actually close to 19,000 already. And New York, as you're aware, being the epicenter, we have over 138,000 cases reported here. And again, this just shows you if the cases that are being reported, are they widespread or are they confined to specific areas defining themselves as clusters of illness? And then finally, the last few states here that have lower number of reported cases. So if you look at New York State alone as, the epicenter of the COVID-19 outbreak, essentially in the United States, you can see that statewide we have over 350,000, about 365,000 people that were tested. And we have about 149,000, over 149,000 people that have tested positive for the illness. So our testing has really accelerated, which has been a good thing because we really want to test as many people as we possibly can. And that's really the goal in all this. The more that we can test people, the more that we can isolate people and prevent further transmission of the illness, and the more that we can do contact tracing, because that's really one of the ways that we can control this. Because as you know, containment of the virus has been essentially very, very difficult because we have such a wide spectrum of illness. So this novel virus is so unique in that you have a huge spectrum of illness where people are either completely asymptomatic and are actively transmitting the virus, shedding the virus and transmitting it, or people have mild symptoms, or people are on the other end of the spectrum where they're acutely critically ill, requiring hospitalization and even intensive care stay. So when you have a spectrum that's so wide, it becomes very, very difficult to really contain that illness. And this, this is where this SARS-CoV-2 is very different from what we saw with SARS, the relative of this virus, this coronavirus. Conversely, with SARS, people usually would get sick very quickly and get very ill, and they would require hospitalization. So it was easier to contain because you knew immediately when the illness was there and you can isolate that person. In COVID-19 and SARS-CoV-2, because people are having so much asymptomatic transmission, that's been the most difficult thing with containment. And that's why our focus has shifted really to mitigation strategies, which, we really need enhanced testing abilities to do that, to see who's in fact, positive for the virus, who may or may not even have symptoms, and who then we can isolate, and how we can trace the contacts of that person to continue isolating people to prevent, further spread of the virus. So as of yesterday, we had, over 10,000 new cases in New York. And, this just gives you the distribution of percentage of males, females. And then on the New York State Department of Health website, it lists down by specific counties where the highest number of cases are happening. But if you just look at this, the map over here, it shows you, obviously New York City and the boroughs, there's very high volume and high percentage of cases. A lot of it having to do with, population density. And, as we mentioned before, the more populated, the more urban areas are subject to higher burden of disease for various reasons. And Long Island, Nassau and Suffolk counties and Long Island have had, growing numbers of cases in the past week. And, we are expecting our surge, essentially in the next few days, moving on to even in the next week. But, for now, we're really focusing on the social distancing, the sheltering in place measures to really sort of help flatten that curve and get us through this. So if you look at the hospitalizations with and without ICU admission by age group in COVID-19 patients and adults, this is data that basically the CDC has from February 12th till roughly about end of March. And if you look at the underlying medical conditions, now this is, obviously what we have been focusing on from what the information that we had following China and then Italy and globally, is that we were expecting that the majority of cases would be people with underlying medical conditions. And although that is true, we are still seeing significant disease burden in younger, healthy people with no underlying medical conditions. We just have to wait to see statistically what that percentage is going to be like. But this gives you an idea of what's happening right now. And then breaking that down farther into, who is requiring that ICU admission and ICU stay, we can look by age group that, majority of that is still those people with underlying medical conditions. And some of these people, the main underlying medical conditions they might have is just, hypertension, high blood pressure, certainly diabetes, two of the most common conditions in the United States. Those are really what we're seeing in our numbers. Now, if you move a little bit globally, wanted to shift the focus a little bit on what could be happening in other places and what there is potential to happen in other areas of the world where we have significant, underserved areas, where we have significant poverty, where we have war-stricken areas, where people don't have access to basic needs and necessities. So, right now we have underrepresentation, reporting of COVID-19 cases in areas such as Bangladesh, Syria, and Haiti. But, a lot of these numbers, on one hand can be some underreporting just from lack of testing. So we know not everybody has the same testing parameters based on their countries. And the other is, we are in this evolution of the pandemic. So with travel comes more exposure, and, we'll have to wait and see, because right now the countries that were affected the most first and foremost were the ones that were most frequently traveled to. But the issue that comes to bay is that, these areas, how are they able to cope with, if they are faced with the overwhelming burden of disease that we are seeing worldwide? It's difficult enough in developed countries, in Europe and in the United States, that we're seeing handling, the volume of patients that we're seeing and the amount of illness that is present there. And the fear is that how are these areas going to handle if they are dealt with, similar circumstance? Because unfortunately, containment and mitigation strategies will be very difficult. As you know, here, what we keep focusing on is really hand washing and hand hygiene and washing your hands for 20 seconds and doing all those things. Well, we know that in areas where there's, unfortunate poverty and, war-stricken areas, that people don't have access to water. And so those, basic efforts become very, very difficult, and and that becomes a huge public health concern. So these are things that are really of concerning globally. So we're going to have to wait and see. But the more that we can get aid to these areas, the better it'll be for the people in these areas. So in closing, I just wanted to say that the most important strategies for us going forward that we've been focusing on in the United States, that we need to do as a nation combined. I like to talk about this a lot when we have certain states that you saw before that were in the lighter shaded areas where they don't have that many cases of COVID-19. Well, people like to feel this false sense of security that, maybe it won't happen here and we can just go on doing the things that we're used to doing and life doesn't have to sort of come to a halt. Well, it really is a false sense of security, because it takes just a matter of days before the numbers can double, triple, or quadruple. And you can see that in this virus that is so communicable, where we thought the R naught, the transmissibility was maybe, from one infectious person being around people, that you could transmit it to between 2 to 3 people. And now the newer studies are showing that it can be as high as over 5 people. So with something that's so highly communicable, we really have to start those mitigation strategies now, really have to do the social distancing now, really have to focus on the sheltering in place now, so that we can have better outcomes, so that we can really flatten that curve and really prevent further mortality that we are seeing so widespread, and further burden on the healthcare system and all of the people that are most vulnerable, those elderly people with underlying medical conditions that are coming to the hospitals, that are requiring that ICU care, that are requiring the ventilators, who are not making it even. So in closing, I wanted to just mention this quote that I thought was so poignant and so apt for now, by the president from the Republic of Ghana. He said that we know how to bring the economy back to life. What we do not know is how to bring people back to life. We will therefore protect the people's lives and then their livelihoods. Thank you.
Thank you so much, Dr. Sayed. That was incredibly informative. I'd like to direct attendees to put their questions into the Q&A, and we will answer them after the presentation. We will now be hearing from Dr. Noor Akris, a MedGlobal board member and infectious disease specialist who focuses on pediatrics. Dr. Akris, would you like me to share my screen so that we can view your presentation?
Yeah, that would be great. Thanks.
Give me one moment, I will have that. All right, can you see my screen now?
Yeah.
Wonderful. And what slide would you like me to start on?
Can you enlarge that to?
Yes, I can.
8? We can start at slide 8. Okay, thank you. So, I was just going to do an update on the pediatric side of the infection, and unlike Uzma's side, the adult side, we're not thankfully seeing as many cases on the pediatric side. So I'm just going to go through a couple of studies that have come out of China. But this is a rapidly evolving situation. So what we say today could be different tomorrow, and information is changing so quickly. So it's really important just to keep up to date about what's going on in the situation in your local area, as well as data coming out from different countries and the different studies that are coming out. So most of the studies that I'm going to talk about are coming out of China, because I just feel like I don't think that the Italians have been producing a lot of pediatric information. And as the pandemic has hit the United States, I think over the next couple of months, we'll have more pediatric information, but at this time, we don't have that many. So at the end of my slide set, there's a reference to all of the studies, and you can take a look at that if you need it. But we'll start with the study from Dong et al. And they looked at epidemiologic characteristics of the 2,100 cases of pediatrics that they saw over the first couple of months in China. And so this was just a case series from January to the first week of February, and they did a retrospective study looking at what kind of patients they were seeing in pediatrics. And so only 700 of them were lab confirmed, and then the rest of them, the 1,400, were suspected cases. So meaning they had respiratory symptoms, but they were living either in an endemic area, or they knew that they had an exposure, a positive exposure, probably from an adult living in their house. The median age in this group was 7, and although there was a little bit more boys than girls, there was no statistical significance in gender, which I think is a little bit different from the adult population, where men are getting affected a little bit more than women. Next slide, please. And so the good news is out of the 94% of these pediatric patients, of the 2,000 pediatric patients that they looked at, either had asymptomatic disease or were mild or moderate. They did describe one death in a 14-year-old, but they didn't describe if this patient had underlying comorbidities. And then if we look at the percentage of patients that were either severe to critical, so in this little table over here, we can see that the largest percentage of children who were infected with the virus and who needed severe or critical support were those children that were under 1 year of age. And as they got a little bit older, they required less of them required severe or critical support. Next slide, please. I think, can you go back one? Yeah.
There we go.
Yeah, here. Okay, so this is another study that came out of China, and this was a case series, a small case series of children looking at their clinical and epidemiologic features also. So this was just a case series of 10 children who were confirmed by PCR and also had respiratory symptoms and a positive known exposure. Their age group was from 3 months to 10 years. None of those children required oxygen. But what I wanted to highlight here is that it took about 6 to 22 days for their MP swabs to become negative. So the CDC has been telling us in the last couple of days that we can call somebody negative if they have 2 negative PCR tests 24 hours apart. So you know, the earliest recommendations were to quarantine for 14 days, and then we thought people would be less likely to be infectious as time went on. But from this study, we can see that and sometimes people shed for a lot longer than the 14 days. And I also wanted to highlight from this study that we now know that there is fecal oral transmission, and that the virus can be found in the feces. And so some patients are presenting with diarrhea-like symptoms. And again, what I wanted to highlight from this study is that some patients had samples that were positive from their feces up to 30 days. So that's really important for parents who are changing diapers and children in the diaper stage. That again, hand hygiene is super important to prevent spread of the disease. And then also what I wanted to highlight from this study was that they found that their mean incubation period, so the time from exposure to actual symptoms, was 6 days. And so that's important in this virus because as Mo was talking about, you can be incubating, you can be infectious, and you can not even know it. So that's why with this disease being so contagious and having a long incubation period, that's one of the reasons that it's spreading so quickly and so fast, because you could be infectious, you could be contagious, and you don't even know it. And so you're going to work, you're going wherever you're going, and you're passing it on to all those people that you're interacting with, because you don't know that you're sick yet, because it takes such a long time for you to present with symptoms. Okay, we can go to the next slide, please. And so this is another study that looked at pregnant women in China. It's again another small case series, 9 pregnant women, and they were looking at if there's intrauterine vertical transmission potential for COVID-19. So they had 9 pregnant women with lab-confirmed COVID-19 pneumonia. All of them, for one reason or another, were delivered by C-section. So it's kind of hard to extrapolate to normal vaginal deliveries in this case. But so all these patients had their babies delivered by C-section, and they tested 6 of them. They tested their amniotic fluid, cord blood, and breast milk, and none of them tested positive for the virus in any of these fluids. And none of the neonates that were born to these women had a neonatal death or asphyxia. And in fact, all of their APGAR scores were pretty high, 8 to 9 at 1 minute and 9 to 10 at 5 minutes. And so again, the important points here are, we have no evidence that the SARS-CoV-2 is prevalent in breast milk. So it's really important to continue to advocate for breastfeeding. But if a mom is positive, we are trying to separate the mom from the baby, but still have her try to breastfeed by expressing milk and having a non-positive caregiver or a healthy caregiver take care of the baby until mom is over her symptoms and over her illness. And again, it's reassuring that we haven't seen any evidence, not just in China, but anywhere else so far, of vertical transmission. And we haven't seen evidence of any patients with amniotic fluid testing positive for SARS-CoV-2. Okay, next slide. And this is another study, again, from China, looking at 33 neonates born to moms with COVID-19 in Wuhan, China. And again, it's a small study, but the information showed that the 33 neonates who were born to the COVID-19 moms, four of them had respiratory distress. One had a serious illness requiring ventilation and antibiotics, but that baby also had concomitant Enterobacter sepsis, so it's hard to say, or it's hard to attribute this baby's illness to COVID-19 only. And then they did do strict infection control, or they tried to, so separating the babies from the moms right away. And so this again leaves the question about vertical transmission, since the babies were, since some of the babies were positive, because they did separate them right away. But again, because there's no evidence across our country and across other nations of positive amniotic fluid, it's hard to say how the babies contracted the coronavirus, if they actually were doing strict infection control of separating them, or if, sometimes we know also like healthcare workers can transmit to babies, especially if they're not wearing adequate PPE and they're asymptomatic transmitters. Next slide, please. So this is my last slide here. This is the MMWR that came out of the CDC just a couple of days ago about the US experience with coronavirus in children. And so again, looking at the 149,000 plus cases that we know in our country, 2,000 of them were positive among kids, which is a very low percentage, 1.7%. And in this report, there was a slight male predominance. Only 5.7% of all pediatric patients were hospitalized. So again, reassuring that in children, this is a generally either asymptomatic or very mild disease. There are 3 deaths in the United States that are still being investigated. One of them was in my state of Illinois. And there's a couple of others that are still being investigated. So we don't have any further information about whether those children had underlying medical conditions or something else contributed. I can share from my own experience. I had a patient who was a 3-year-old who had underlying medical conditions. He had BPD, he was an X27 weaker, he had seizure disorder, and he came in with a severe pneumonia requiring 10 liters of oxygen by heated high flow nasal cannula. He tested positive for human metapneumovirus. And so initially our team, or the hospital's team, attributed his illness to just human metapneumovirus. But then I had him tested for coronavirus, for COVID-19, and he tested positive. So I think, I don't know if I deleted the slide, but there is another study out of China that reported there was 40% co-infection in children. So meaning in the beginning of the pandemic here in the United States, especially in Illinois, I was, obviously I'm following the IDPH guidelines, and so the Illinois Department of Public Health wasn't allowing us to test children or other patients who had a severe pneumonia. So this is at the very beginning, so maybe like a couple of weeks ago, 2 or 3 weeks ago. So they were not allowing us to test patients who came in with a severe pneumonia, who had another either viral illness or bacterial illness that we could attribute to causing their pneumonia. But in the study that came out from China, not this one, but another one in pediatric pulmonology, they shared information that their patients, they had a 40% co-infection rate. So just because a pediatric patient specifically has another viral infection, a known viral infection, whether that's RSV, human metapneumovirus, or something else, that doesn't mean that they're automatically negative for SARS-CoV-2. So it's really important to still test them, to know their status, and to know it's more for epidemiologic data, so what the healthcare workers you are exposing, or hopefully not exposing if they're using adequate PPE. So in any case, so that's an important highlight or pearl from these studies also, that children can be co-infected, as I'm sure adults can, but more specifically in children, that happens more often. So again, so the 3 deaths are being investigated. We still don't know if they had underlying conditions. And in the report coming out from the CDC, they talk about that the children were less likely, or had didn't have as many reports of fever or cough as the adults did. So So again, children can be asymptomatic, or they can present with other symptoms like GI illness, diarrhea, sore throat, things like that. Okay, next slide. So again, with the children who were sick with coronavirus, 13% of them had underlying medical conditions, and just as I discussed with one of the earlier studies from China, children under 1 year of age accounted for the highest percentage of hospitalized patients, pediatric patients with COVID-19. And the most common underlying conditions were chronic lung disease, like my patient who had BPD, or asthma, and other underlying lung disease, cardiovascular disease, and again, specifically the immunosuppressed children were the most likely to be hit hard by SARS-CoV-2. Obviously, there's a lot of limitations in this study set because we're just taking in information as we're getting it. There's a lot of underreporting, under-testing, and more likely we're getting reports of the cases of severe disease as opposed to people reporting pediatric patients who have mild disease, because that's not as interesting. And that's all I wanted to share in terms of the pediatric side. So we can move on to the next part of the presentation.
Wonderful. Thank you both so much for those incredibly informative presentations. I know as a person with a non-medical background, one of the most frustrating things for me is being able to trust the information being presented. So, you know, I know myself, and my recommendations for the people in my community is to be, you know, going to the source, going to things that are, you know, coming from the CDC, coming from the WHO, things that are, you know, like your presentation, very factual. So I'm very grateful that you were able to share that with us. I would love now to go through some of the questions that were submitted by our attendees. I'll pose them to both of you, and if one or the other wants to answer, please, I will let the two of you decide between yourselves. And if neither of you feel like you'd like to answer, we can move on to another one. So somebody asked that they heard that patients with low kidney function might have a higher rate of intubation, and if this is true. Oop, Dr. Usmed, you are muted.
That would help. So I was just saying that, you know, people with underlying kidney disease, you know, chronic kidney disease, end-stage renal disease, needing hemodialysis, you know, that is an underlying medical condition that puts you at higher risk of having, you know, being at more risk of acquiring COVID and having worse outcome, rather, not acquiring it, but having worse outcome with it, requiring hospitalization and even intensive care units. So the fact that somebody might have that underlying medical condition who's on dialysis, that's one thing that is predisposing them to having a worse illness, more severe illness, more requiring more intensive care stays. So that could be the correlation with, you know, needing mechanical ventilation, intubation. But it's not correlated specifically that just because, you know, their kidneys, that there's a problem with the kidneys, that they're going to need the ventilator. I mean, it's complicated. So there's many different things that are happening. The virus itself, the illness itself presents itself, you know, it's a respiratory illness, but then it affects many of your organs. So one of the characteristics of it, whether or not you have a baseline, you know, underlying kidney problem, is that people that do get sick enough with this, that are hospitalized or in critical care, they do have, their kidneys do get affected by it. So eventually what happens is it not only affects your lungs and your respiratory system, but it can affect any of your organs. So, you know, as you start having effect on all of your organs, the kidneys being one of them, you know, your kidney function deteriorates. And then some of these patients require, you know, additional, you know, whether it be hemodialysis or other things to support, to maintain their kidney function.
Mm-hmm. Thank you. Another question, if there is widespread testing, is it anticipated that there will be a lot of asymptomatic / pre-symptomatic cases? And who will actually be doing the contact tracing? Is there adequate public health staff available? I'd like to just tack another question onto this one because I think they go together. But if you could also speak to the different types of testing available as part of this, that's kind of combining two questions from our attendees.
Go ahead, Uzma.
Okay, sure. All right, so that's a great question, actually. Just I hope I answer all of the parts. So widespread testing, I think, we, as I mentioned before, we are getting there. We still have a ways to go. But if you look at, just for comparison, South Korea, who really rolled out the best, the most effective way of testing and, identifying, people that had the illness. So we need essentially like massive, large scale testing abilities. And in that, you will find, I think it's absolutely important to test people, contacts of people who don't have symptoms, because that's how you're going to pick up those asymptomatic carriers, and then start isolating those people so that you prevent further transmission of the illness. And what was really interesting with South Korea, they were so, smart about it. Not only did they have, an app on the iPhone and things like that, but with their widespread testing and their data driven, they were able to find actually the majority of their population that was affected by it was very interesting. It was actually younger females. So, we might be able to identify the people that have those asymptomatic, the mild illness, the people that we're not expecting to even show up to the hospital. And this way we mitigate, contain it further. What was the second part of the question? Sorry. What are the testing modalities? So the testing modalities that we have right now, the way that we're testing is a nasopharyngeal swab. So it's a swab that, goes inside of your nose to the back of your throat to really where we have the highest concentration of the virus. And it's a PCR test. So that's the test that we're using right now to diagnose everybody. When initially things had rolled out with the CDC, we were requiring two different tests. One was the nasopharyngeal going in the back of the nose into the throat, and one was oropharyngeal going inside of the throat, kind of like a rapid, like a strep test that somebody would do a throat culture. But quickly, as our number of cases started, picking up and evolving, and as our testing abilities were sort of, halted for myriad of reasons, and our, from lack of swabs and things of that nature, whatever rate limiting step was there, we quickly got recommendation from the CDC to just take one specimen, and that's sufficient. So that's really our testing modality right now. They are working on developing antibody testing, but there's no FDA approved antibody test that's available just as of yet. There's a lot of commercial kits that are out there, but there's a lot of disparities between how good these kits actually are. So at this point, we don't have a fully functional FDA approved antibody test. And that testing also is not necessarily going to be that have the illness right now. It's really more for people that may have had the illness who have now recovered.
Thank you. Thank you very much.
Did I answer everything?
I think the last part of that question was, in your opinion, is there adequate public health staff available for these testing modalities?
Yes, that's a great question. I personally think we need a lot more resources from the public health perspective. Again, we're dealing with a novel virus of a global scale, and the numbers that we're seeing just in the United States alone is just remarkable. We've never dealt with this, at this scale before, and we certainly, we have great measures in place, but not at the level that we need to, really have all this contact tracing and put, make it very effective. So I think this is a great opportunity. It's a great learning point for us to sort of move forward from this, so that we do invest in those resources now, so that, if we are to be faced with this again, that we are prepared and we have the adequate response.
Absolutely. I have a question for the both of you. I would really love to hear your answer. One of our attendees asks, hold on, I lost it. Who, as doctors, are both of you trusting as expert sources? Who should we be listening to right now?
So obviously infectious disease doctors, we should be listening to them. And I think that we should be listening to physicians who are on the ground in major hotspots. So like New York City or, California, in areas that they're seeing a lot of patients quickly. ICU physicians also, because they are getting the brunt of the very critically ill patients who are coming in with severe COVID-19. So I think infectious disease, epidemiologists, critical care physicians, and really physicians that are in the hotspots. I also wanted to add to Uzma's answer to the last question. I don't know if they're doing this in New York City, Uzma, but Abbott, so it's a big lab in Chicago or in Illinois, is also doing rapid NAT testing. So like a 45-minute RNA detection also in the nasopharyngeal swab. So that's a faster test. I'm not sure how validated it is so far. I think it's going to be equal to the PCR testing, but that's also another modality, which is kind of similar, but it's just a faster swab, faster answer.
Thank you both very much. Somebody asks, should healthcare workers who are on a COVID unit all day isolate from their family members?
Go ahead, Isma.
Question. So, essentially we're all in the thick of it. Am I muted? Oh, no, you can hear me. Okay. So we're all in the thick of it here in New York and throughout the US as, the number of cases evolves. But this is, something that there's no right or wrong answer to this, but it really is a matter of, how much exposure there is, what your situation is, because every individual is going to have a different scenario. For example, there's a lot of healthcare workers who have extensive exposure, and they have removed themselves from their houses. They're staying in alternate areas, whether it be a hotel or, you might have heard there's some people that are giving out RVs for physicians. So, they have alternate, locations where they're staying at in the hopes of not exposing, their family members. Again, that might not be an ideal scenario for many people when this is not sort of a 1 week, 2 week sort of scenario where we're sort of in a pandemic where we don't know where the end point is. We do know that, with our mitigation strategies, we're hoping to flatten the curve, but that doesn't mean that the burden of the disease is going to go away. It's just going to, lessen on the healthcare system and on the community, but there's still going to be exposure that's going to be happening for weeks to months. And then there's always this concern about a resurgence in the fall. So, for a lot of people, that scenario is not really sustainable to be, outside of your family. And again, a lot of people are the primary providers for their family members, so they don't have that luxury either. So the next best thing after that is to really, use the most, the best practices to really prevent the amount of, exposure that you could have to potential family members. And obviously, as long as you're feeling well. If you're not feeling well, then there's recommendations for that as well, to try to isolate yourself from your household as best as you can, whether it be in a separate area of your house with a separate bathroom or just, outside of the house if you can. But that being said, if you're generally healthy and feeling well, the most appropriate thing, the most important thing is the adequate decontamination, so leaving all of the things that could contaminate from work outside of the house, coming in and then, showering and completely, trying to disinfect and decontaminate before you are around your family members. Still trying to maintain a little bit of distance from the household contacts, especially if you have elderly, family members or people whose immune systems are suppressed, trying to maintain that. And again, the constant hand washing, the, wiping down of surfaces, the frequent, heavy traffic areas, whether it be the kitchen, the common areas, completely wiping those surfaces all the time. Those are the things that are going to eliminate, further transmission if you are in fact, harboring something.
Thank you. Anything you would like to add, Dr. Akris?
No, just like Uzma said, like everybody has to make their own decisions based on their own, your family best, who lives with you, who you're exposed to, who you're exposing, and how much exposure you're having. So I think everybody has to make that case-by-case decision.
Absolutely. So there's a question in the Q&A about if there should be multiple testing, like multiple rounds of testing. Should somebody be tested again and again, including serology?
I can take that. So like Uzma said, the serology testing hasn't been FDA approved, so we don't really know if it's accurate. So like with other diseases, for example, like CMV, for example, cytomegalovirus, we know that if you have an IgM positive IgM, you could have a false positive. So until that serology testing is validated, I think that's not going to happen. But in terms of repeat testing, we do have cases in the hospital, for example, that, the first initial test is negative, but we still have a suspicion for COVID-19. So we will retest them, more than once. The sensitivity of this test, the PCR test, is about 70%, which means about 30% of patients will have a false negative. And that also speaks to like how adequate your sample is. So if you're whoever is getting the sample isn't getting an adequate sample, so whether if they're not getting into the back of the throat well enough or not getting enough of the sample, you can have a false negative, meaning that you actually have the virus, but the test comes back negative. So there are cases in the hospital that we are testing more than one time. And so again, like the clinician has to use their best judgment if they think that they got a false negative on the first try.
Thank you. One of our attendees asks, why are COVID patients so at risk for ARDS, ARDS?
Asma, I'll defer to you for the adult side.
Sure. So, I mean, as I was mentioning before, there's a whole myriad of effects of this virus. And, we know already from the symptoms being really wide spectrum to, the actual clinical illness that presents itself. So one of the sequela of the illness is, people end up having this, ARDS, which is the finding that you see in the lungs. And, it's very, very common. So a lot of times, just referring back to the testing, what we're seeing is, the patients are coming in with really very classic presentations, not necessarily symptoms, because a lot of them will have the fever and cough and things like that, but then you'll see the x-ray findings, and then so as the disease progresses and it gets more severe, when these patients, they start deteriorating and most of them requiring intensive care stay, is that they see the ARDS is developing in the lungs, and there's lots of different mechanisms for it. There's a lot of things happening with these patients where they're having like a VQ mismatch, they're having shunting, they're not oxygenating well. And it's not the typical mechanism of ARDS that we're used to seeing in other pathophysiology. And so the treatment is really what's different. So, typical strategies for ARDS is, using steroids and things like that. And that's not usually our approach for COVID, because it's actually been found especially early on, to have worse outcome because of prolonging the viral shedding and decreasing the excretion of the virus. So we're still learning a lot about this novel virus. We're still learning a lot about the disease that it causes. But we do know that that's one of, the more severe, presentation of the illness that is actually rather common.
Mm-hmm. And would you say, the last thing that you said speaks to one of the other questions, because we're still learning about the virus, is that why, in your opinion, different infectious disease doctors are providing different recommendations?
So I think the issue that we have is multifaceted. So it's a novel virus. Nobody's been exposed to it ever before, which is why we don't have immunity, and there's no cure for it. So when you have something that's so communicable, that has so much illness and so much mortality, there's always this, especially in medicine, we are used to curing people. We're used to, nursing them back to their health. We're used to having so much technology, so many medications, so much innovation in science, where we're used to seeing people, recover from their illness. And in this case, we don't have that. And so there's so much information that's coming out at such a massive rate from all over the world. So there's, journals that are coming out that are pre-printed. There's, it's literally by, you could count by the hour how much literature is coming out, because everybody's sort of trying to find something that's going to work for this. And that's why right now there's really no FDA approved treatment for this. Everything is anecdotal. And that's why you might hear different people talking about different, scenarios and different options, but everything is a theory still, because we still are learning so much about this virus, and we don't have everything in science is data driven. So we need to have the numbers, and we need to have the real, good studies to prove that what we're doing is having good outcome. That's when we can say that something has clinical benefit.
Mm-hmm. Thank you very much. We have just a few minutes left in the webinar, so I'd like to invite either or both of you to share any closing thoughts, recommendations, anything you'd like people to take away from this webinar before we finish today.
I'll just go first, and I just want to, again, like, it's really important to listen to your public health department and what your public health department is recommending. So everyone's situation is different in terms of their locality, but it's just really important to listen to those instructions. And then secondly, obviously as a MedGlobal board member, I just want people to think about, your situation may be a lot different than people in refugee camps who don't have access to water and soap, who don't have access to alcohol-based sanitizers, who don't have access to the possibility of quarantining or social distancing or keeping a sick member of their family in a distance from them. And so if you just remember that and think about these people and try to help us, MedGlobal, to provide PPE to doctors who are taking care of these patients, whether they're in Greece in the refugee camps or in Colombia taking care of the Venezuelan refugees, or Yemen, the displaced people in Yemen due to the war, Bangladesh, or the Gaza Strip. Please think about those people and support MedGlobal in trying to help us provide PPE to our physicians there.
Thank you, Dr. Akris.
Yeah, I concur with that. I mean, that's really what's important right now. But I also want to just stress that, you know, we are in a unique situation in this country and throughout the world. And really, as I mentioned before, that there's no cure for this and there's no prevention for it. We don't have a medication that's proven to be effective as of yet, and we don't have a vaccine that's available as of yet. So the only way that we can really tackle this disease is by the entire world coming together and doing what's necessary. And what we see is really going to help is the continued, you know, social distancing and sheltering in place. And it's certainly an inconvenience for the short run, but in the long haul, it will be saving lots of lives. And I think we just have to focus on that.
Thank you very much. This webinar has been part of MedGlobal's COVID-19 response. We ask that you visit our website, medglobal.org/COVID-19-response to see what our rapid response goals have been. We ask that you support our efforts to provide our colleagues in disaster regions with protective gear during this epidemic. Our goal is to support 500 doctors and nurses in each country of that we work in: Syria, Yemen, Bangladesh, Pakistan, Colombia, and Gaza for the next 3 months. Something as low as $20 will protect one nurse or doctor for 1 day. So we ask you to visit our website, to make a donation, help us help those who will be hit the hardest, so we can provide soap, personal hygiene kits, much needed medical supplies, the ventilator that we just fundraised for in Gaza, as well as education and training and mental health support. We're trying to have a very well-rounded and multifaceted approach to providing support to healthcare workers worldwide. Tomorrow we have a webinar about our work and response in Syria. You can visit our social media and our website for all of the upcoming webinars. We'll be hosting several a week. So we ask that you join us. And I want to thank both you, Dr. Akris, and you, Dr. Syed. Again, this was incredibly informative, and I can speak for everyone involved that we're so grateful for the time you gave us. And we look forward to hearing from you again.
Thank you so much.
All right. Have a wonderful rest of the day and stay safe.
Thank you. You too. Bye-bye.